I'm Victoria Christian, Chief Operating Officer of the Duke Translational Research Institute. We're here today to talk about the MURDOCK study, an ambitious collaborative project with potentially far-reaching impact on human health. The study is funded by a gift from David H. Murdock, owner of Dole Foods, Castle & Cook, and founder of the North Carolina Research Campus. The study initiated in January 2008. I'm joined today by one of the study's investigators, Virginia Krause, rheumatologist with a background in genetics and biomarker discovery, who serves as one of the principal investigators for the osteoarthritis component of the MURDOCK study. Welcome, Virginia.
Thank you, Vicki. It's a pleasure to be here.
We're also joined by Dr. Cecil Charles, a chemist by training who serves in a leadership capacity for the Duke Translational Research Institute Imaging Corps, is founder of the Duke Image Analysis Lab, and serves the MURDOCK study as co-investigator of the OA project. Welcome, Cecil.
Thank you. Nice to be here.
Virginia, I wonder if you would start us out by giving us a brief summary of the study design of the MURDOCK study.
This study is a very ambitious, multifaceted project that is most readily summarized on this slide. It has several components. And through the gift of Mr. Murdock, we were really given the opportunity to develop some brand new diagnostic tools for osteoarthritis that we hope are going to improve patients' lives and facilitate the ability to generate new medications for this. But this Horizon 1 is what we call it, is a discovery phase in which we are working very strenuously to try to find new tools for diagnosing this condition and for prognosing, which means trying to pick people at risk for the disease progression. It's eventually going to require large sample repositories and a community involvement in order to take these findings and validate them and actually apply them in the real world.
Thanks, Virginia. We describe the study as molecular epidemiology. I wonder if you would explain to the viewers the difference between molecular epidemiology and a classic genetic study.
A lot of the science until just in the last really decade has been siloed. It's been a single type of science. What has happened with the revolution in genomics and genetics and proteomics is that now people are looking very broadly at these tools to try to bring everything to bear to try to improve the understanding of health and disease. And so molecular epidemiology is the umbrella under which all of these things fall, and it requires moving out of silos and for laboratory scientists to work with clinicians, to work with epidemiologists, and to work with really creative statisticians to try to get at some answers that have been, until now, really, we have never been able to touch. So that's what this whole endeavor is. It requires a very devoted team of people working closely together to make scientific discoveries that are going to really impact health in a big way. And so molecular epidemiology is a great term for that, since it encompasses all of those previously siloed individual types of science.
Great, thanks. Where did the biological samples and the clinical data that you've started this Horizon 1 of your project come from?
We had already done a number of studies in a couple of different cohorts, and one in particular was one in which people provided not only clinical data but synovial fluid from their knees, their blood, their urine samples, and that particular population came out of a study looking at people over about 3 years to see how their osteoarthritis progressed. And this is a very unique time to be able to do that because there are really very few treatments for osteoarthritis that impact it. So what we've been able to do is see how do people progress really naturally. Ultimately, we want to impact that. And so this particular study that we call the POP study was one in which people from the neighboring regions of North Carolina and a few neighboring states came for 2 visits at baseline and 3 years later. And I have an example of 2 people that participated, and I just wanted to show both their x-ray, which is at the top, and their bone scans, which are at the bottom. And on the top left is the knee x-ray of a single individual who then came back 3 years later, and their x-ray from 3 years later is on the top right. And what you can see from this x-ray is that this particular person had a tremendous amount of progression in their knee. And in the inside, which is the top left panel on the left side, there's a certain amount of space between the bones, and that's where the cartilage is. And it's invisible to x-ray and looks like there's nothing there, but what's really there is cartilage. Over the course of 3 years, now if you look at that same spot on the panel on the right, there's almost no space left. So the cartilage is almost completely gone. And what if you look very carefully at the corners of each of the bones that surround the space of the joint, new big spurs have grown up, which has been the body's attempt to try to repair this process and buttress the joint. But in fact, it usually leads just to more pain in the joint. And what is even probably more visible to a layperson's eye is at the bottom. You can see on the left-hand panel on the bottom a bone scan that was done at baseline and then 3 years later. And here where we saw all of that cartilage loss, the bone adjacent to that is very, very hot, lighting up, which means that that is an area where the bone is being turned over massively, and it goes along with the progression of the disease. So this is one example of one person who participated, who's going to be providing through this study some synovial fluid that has been banked away, providing synovial fluid for analysis to help us to develop new biomarkers for the disease to pick up progression. And the way that we're going to be able to compare that person and find a biomarker of progression is to compare them to the synovial fluid from an individual who was fortunate enough not to actually progress over 3 years. And that's what's shown here. And if you get up very close and look carefully, this person actually had a bony spur on the outside of the joint. So if you look at the top left panel, on the right side of that top left panel, there's a tiny spur on the bone on the bottom, and it didn't change at all, and the space between the two bones didn't change, and their bone scan at baseline, which is the bottom left, it was pretty quiescent and stayed quiescent over the course of 3 years. So by comparing the fluid in the knee from these people to the other individuals who had progression, we hope to find those molecular signatures that are going to be indicative of disease progression, and we won't have to wait 3 years before we find the person who we need to treat or don't need to treat.
Wow, thanks. Cecil, I know you're interested in using imaging, digital images and imaging technologies to understand this disease. I wonder if you could tell us what it is you seek to understand from looking at images in osteoarthritis.
Well, in most types of osteoarthritis, imaging, in particular X-ray imaging, is really required as part of the diagnosis. Further, the FDA guidance associated with looking at treatment options, trying to develop treatments for OA, really require radiographic evidence if you're going to make a labeling claim that you're curing or treating the disease. In this particular study, what we're interested in doing is looking at some of the images that Dr. Krause has shown you, and in particular the X-ray images. Because what we're interested in is, as she said, early detection and ultimately the ability to predict what's going on. The particular thing we're looking at really involves structure of the bone, not external structure, but the structure inside the bone that gives the bone strength. If you think back to those two images that Virginia showed, basically those hot images in the images, the lower images, all of that information is in the bone area. We want to be able to understand that in a little bit easier way from X-rays. And perhaps the easiest way to think about this is in this slide. If we think about the structure of the bone inside the bone, we can think of this like a building where we have both columns and beams. The columns go up and down, the beams go across. The columns act to support the compression load, the biomechanical loading of your body on the joint. And then, of course, the beams in a building act under tension to keep the columns from collapsing and the building falling down. Likewise, for each of the beams themselves, you have compression at the top of the beam and tensioning along the bottom. Now, This, of course, is an idea from a building. Why do we care? Well, if we think about this in the context of the X-ray image, in this area shown in blue, we're looking at the what's called the trabecular structure of the bone, and the bone is not solid there. You can think of it as kind of a honeycomb structure, and that honeycomb structure gives it the ability to resist this huge compressive load that goes on when we walk. The tensioning, again, both of these help to support the bone. The idea is that we would like to be able to extract some information about the trabecula. In the upper left, you see a 3D representation of what this so-called trabecular or honeycomb-like structure looks like in the bone. And while it would be nice to be able to get images like this easily, there are a lot of technical issues associated with that. On the other hand, when we look at X-ray images, which are very common, it's a technology that's ubiquitous, you can get it just about anywhere. When we look at the texture of the X-ray, as you see in the image on the upper right, and then magnified a little bit in the lower panel, what we see in that texture really is the two-dimensional projection, the shadow that we see from the X-rays going through the bone, and it reflects this trabecular structure. So our idea is to use a technique of analysis of the texture to look at the structural integrity of the bone and use that as a way to look at this issue of bony remodeling that Dr. Krause has alluded to. The idea is, can we see these changes early on? Many of the things that we look at in images in osteoarthritis, like joint space narrowing related to cartilage loss, are important in a way, but may actually represent things going on later in the disease. And what we really would like to be able to do is say something about what's happening in the early phases of the disease, especially in the context of developing a treatment and deciding whether the treatment's working. So that's the point of using these types of images and using it with a software technique that is basically automated to minimize the overall cost and make it easy to do this in large numbers of images. In this study alone, we're looking at several thousand images, so if you had to do some analysis like this manually, it would simply be impractical.
Clearly, and it would also be obviously impractical to get these X-rays and associated clinical data if you were starting today. So it's a spectacular opportunity for people with a repository of biological specimens and that are well annotated with a well-controlled clinical trial. I wonder, we've both used the word ambitious. There must be other members of your team, and I wanted to invite you to let us know who your collaborators are and tell us a little bit about what their roles are on the study.
I would say that the MURDOCK project really has almost become like a family, and within that family there's a little nuclear family, which is the osteoarthritis team. And of those, the aspect that I mentioned before, which was the synovial fluid analysis and eventually blood analyses, are being done in collaboration with Art Mosley, who's the director of the proteomics facility at Duke, and Will Thompson, who's the laboratory administrator there, both extremely knowledgeable scientists with regard to biochemistry and proteomics. And in my laboratory, Dr. Jonathan Catterall, who's a PhD biochemist, who has lots of cartilage experience, a decade's worth, that has gone into helping us to develop the new kinds of techniques that we even need to be able to do this science. There are others.
So Dr. Sheng Feng is an assistant professor in biostatistics and bioinformatics. His background in statistics is in methodology and microarray analysis and proteomics analysis, which makes him uniquely qualified to look into this data. Further, he's using some of the tools that he's developed in this, working with the people in the Duke Image Analysis Lab to address the issues of image analysis, because the nature of the data we're extracting from the image data is multidimensional in nature. And that's been an interesting issue to deal with from an informatics viewpoint. We also have a couple of people in the Duke Image Analysis Laboratory that probably are of note. Maureen Ainsley, who's the lab manager for the group, has over 30 years of experience in imaging and a master's in gerontology, and she handles a lot of the day-to-day operations in the lab. Scott White, who's our data manager, has been largely responsible for the data conditioning of the several thousand x-rays that we are using in this study, and he interacts very closely with statisticians, and with Dr. Krause we meet roughly weekly to go over this analysis. The kinds of tools that are being used both statistically and from a viewpoint of image analysis in this are novel and basically are, I won't say they're outside the realm of all analysis that is going on, but it certainly is a unique analysis, particularly in conjunction with the proteomics and the other biological strategies that are being used in this overall study.
Great, thank you. Can you, I'm fascinated by these pictures you've generated and by the different ways that you're looking at these data, proteomics assays and image analysis. Can you tell us anything about the early signals that you're seeing in this first year of the study?
So far, I'll speak to the synovial fluid. We have done a number of pilot studies that, that have enabled us now to finally hone the procedure for dealing with the synovial fluid. Most people don't realize it's this very gloopy, sort of thick glycerol type of fluid, and if you try to put it in a machine, it will ruin the machine. And since these are multi-million-dollar machines, we're not very popular for that. So one actually has to figure out how to chew up that and get rid of that thickening fluid, but still not chew up the proteins in a way that would prohibit you from finding the signals that you're looking for. So we have actually spent several months intensively working to develop a methodology, and so we have that now in place, ready to go forward and look at these very precious samples. And we wanted to make sure that we had actually had the methodology because these people have given these samples through time and energy and discomfort, and they're very, very precious. So we wanted to make sure that we really knew what we were in for. As far as the image analysis, we do have some very promising looking preliminary results where we're actually looking at what are the effects on this honeycomb structure that Cecil showed, and what are all of the impacting factors like your weight, your age, your gender, your bone density, and also your state of osteoarthritis and your risk for progression. And right now we're actually able to show tremendous differences in terms of those different factors, which leads us to be very, very positive about this whole endeavor, being able to find some factors that are going to really be able to be translated into a community study.
Yes.
That's great. So tell me something about the second horizon. You explained that once you generate your biomarkers or your hypotheses about ways to improve prediction or predict response to therapy, you will be testing those hypotheses. Can you think a little bit about how those hypotheses might be tested specifically in Horizon 2 of the osteoarthritis component?
We'd really like to do two things, Vicki. We'd really like to both help doctors and help patients. With this exciting opportunity, we're hoping to be able to help doctors to have more tools at their disposal to understand their patients and what's going on with them. So blood tests, urine tests, and some new ways of analyzing the x-rays that they're already getting, but not actually taking full advantage of the information that's there, which requires a lot of statistical and analytic expertise, but that could be developed as a tool that could then be delivered to them and they could use in the clinic. So we're hoping that that will provide new tools to doctors, and that ultimately these tools are going to make clinical trials less risky to drug companies who right now see that waiting 3 to 5 years to tell if their medications are working or not in a clinical trial scares them off from even wanting to make the effort to find a cure for osteoarthritis. And so of all the different types of arthritis, probably osteoarthritis is the most far behind because it has been so hard to tackle. So we're hoping these new tools will provide new ways of telling if your medication is working earlier and more robustly, so that then we will help facilitate the development of cures for this disease and not think that it's impossible to develop a cure for the disease.
Great. So I know that you're also involved in trying to make this a community-based study. And could you talk just a little bit about the registry and how you see the registry facilitating Horizon 2, and how the activities of this study, the interactions with Duke scientists, are going to impact the people of Kannapolis?
Well, for the answer to the first part of that, the registry is very critical. If we're going to move to the second part after this discovery phase, to really test this in a separate population, we're going to need to be able to identify some of these factors that are coming out of the discovery phase so that we can choose the appropriate people to look at. That is a critical piece of the registry. Without the registry, you simply can't go to the next step. The other piece, which we're already beginning to do, working with rheumatologists and radiologists in the area, is establishing these different ways and better ways of obtaining imaging data and working with them so that we can help them get information they already use clinically, but also begin to extract some of these other more advanced tools which we're going to use to answer the research question. We think that that has both a long-term, obvious research benefit, but also a short-term benefit in making it easier for the clinician to extract information, and we're going to make some of this information available even before we get to Horizon 2, working with the clinicians in that community to let them see how we can sort of help them out with some of this computerized analysis that will help them even in their clinical practice.
Great. So tell me how the massive core lab that David H. Murdock is constructing on the North Carolina Research Campus will factor into the study. What's the relationship?
The core lab provides almost a wonderland for a scientist. I am not underestimating that. I think just to walk through it and to realize the potentialities there is an amazing experience. And what we're hoping to do is to further broaden our horizon, so to speak, and be able now to fold in genetic analyses in addition to proteomics and image analysis. And we have available a pre-existing cohort, again, of people from all over, actually, the United States, a large number from North Carolina, who have participated, who have osteoarthritis of their hands, their hips, their knees, and their spine. And for us to be able to do the genetic analysis in a high throughput lab where good clinical practices and quality control are being done so that the data are going to be outstanding, excellent, and then have available the statistical analysis to go with that. In other words, it's all one big package deal. I think that we'll be able to even further facilitate that process, which is what I said about trying to really go for a cure and not think that that's an impossibility.
Wow, how exciting. Well, I know we're going to want to talk to you again about this study as it progresses, but right now I'd just like to say thank you so much for sharing and being here to let us know what's happening in the osteoarthritis component of the MURDOCK study. Thanks, Virginia and Cecil.
Our pleasure.